Hello, Dr. Michael Mirander here again on another Medical Minute. And today we wanted to briefly touch on anticoagulant therapy. When you realize that 0.01% of the American population does have a propensity for deep vein thrombosis on an annual basis, and that anticoagulant treatment is the mainstay of preventive and therapeutic management of these thrombotic episodes, then we realize that this is something that needs careful attention, because the main drug that seems to be utilized in a long-term fashion is that of the vitamin K antagonist, wafarin. However, in a more acute setting where persons might have a DVT, there are different modalities of treatment that are anticoagulants that are used. And usually, probably a common scenario would be somebody who is having pain in the back of the leg that might be associated with some increased warmth, some swelling of the leg, and definitely tenderness. If you push back on the foot and stretch the calf area, it tends to be painful, which would be considered a positive Homan sign. Of course, venous thrombosis can occur more proximally, for instance in the thighs, and the more proximal it is to the heart, then is the more chances of you having a clot that can go on to the lung, which would be regarded as a pulmonary embolism. When you realize that this has a 17% mortality rate in a 3-month window, then you realize that the treatment of venous thrombosis is an important medical condition. As far as the FDA is concerned, people with an acute thrombosis would need to be hospitalized, because the usual modality of treatment is using unfractionated heparin at that time, which is usually given in a dose of about maybe 8 units per hour on a continual basis after a bolus of about 80 units. And then the dose continued to be 8 units per kilogram per hour. And this is usually bundled with the Coumadins, and you can monitor the heparin efficacy by following the APTT, and you're looking for a range of 1.5 to 2.5 that are normal. And as you start a heparin, a lot of times you'll be looking for the side effects of thrombocytosis, thrombocytopenia, heparin-induced thrombocytopenia, and the propensity to decrease the platelets is there. So you'll have to monitor the platelets and the APTT to make sure you don't run into problems with the heparin. Anyway, as I said, concomitantly, warfarin is usually started, and once you get to a therapeutic level of the INR of about 2.5, then usually after about a 5-day course of the heparin, one can gravitate to the sole use of the Coumadin, and then that patient will be DC for home care and home monitoring, or monitoring of the Coumadins. However, in the field, although not FDA approved, people often use the low molecular weight heparins, and in this area we tend to use Lovenox quite frequently. Usually the dose is about 1 unit per kilogram Q12 hours. The other thing that's used is the Framgen, and Framgen dosage are about 100 units sub-Q, or Q12H, or 200 units per kilogram Q24 hours. And as I said, a lot of times these low molecular weight heparins are just used to get to a therapeutic level, because a lot of times Coumadin is started concomitantly with the low molecular weight heparins, and then we would continue long term with the Coumadins. Generally, treatment would last for a minimum of about 12 weeks, after which one has to evaluate whether you need to continue the use of the anticoagulants. For people who have, like, say, artificial valves, more than likely the treatment is going to be long term, almost lifelong. And people with probably a history of a pulmonary embolism, a lot of times those people are going to be on Coumadin well past a year. People just one incident of a DVT, certainly within about 3 to 6 months, your doc would probably discontinue the use of Coumadin, unless you really have some high risk factors like cancers or morbid obesity, or very poor kidney functions. Then one would probably keep the Coumadin going for a long time. Should mention that there's a lot of adversities with Coumadin, and it needs to be monitored. Certainly, the Coumadin is usually started at about 5 to 10 milligrams.
Sandra from customer service, please call the operator. Sandra, please call the operator.
In a regular person, in an elderly person, one tends to start with 5 milligrams, or a little less than 5 milligrams. Oftentimes, I would choose 3 milligrams. But as I said, if the initial day you might double up on that for a day or two, and you seek to check the INR within about 3 to 7 days. After that, you might be monitoring the INRs for the Coumadin efficacy almost every week, every 2 weeks, or every month, depending on how stable the INR becomes with the particular dose of Coumadin that you take. There are genetic influences on Coumadin that make some people more sensitive to it and or less sensitive to Coumadin. And we've not reached a point where genetic testing is approved routinely, but it might be something that happens in the future. Now, there are a lot of people on Coumadin. Coumadin is, as I said, used in these people who have DVTs, people who have atrial fibrillation, certainly people who have had a pulmonary embolus, people who have had who have artificial heart valves, are maintained on Coumadin, and so they can be on that for lifelong, and you really need to follow it and to monitor it. As I said, sometimes the therapeutic range for DVT would be about 2.5, what's normal for the INR. So most times upper limit of normal of an INR is about 1.2. So you're trying to get to a range of 2.5 on the INR. And if you're monitoring it and let's say you have a level of about 1.5 to 1.9, certainly in a case like that you tend to maintain the same dose of the Coumadin. If the INR is about 2.5 to 3, then you're thinking of decreasing the Coumadin dose from, I would like maybe about 25%, but other suggestions is that you might want to decrease the Coumadin dose by about 50%. Certainly if the dose is above, if the INR is above 3 when you're monitoring the Coumadin treatment, then you want to be really careful in this situation. If the person is not bleeding, then what you might do is hold the dose, and you might consider decreasing by about 50% that dose on the Coumadin. If the let's say for instance the INR is between 5 and 9, and they're not bleeding, again you can hold a dose or two, and then consider whether you give some vitamin K orally. Usually about 2 to 3 grams of vitamin K is what they use, and reinitiate the Coumadin in a couple of days, because vitamin K will usually kick in within about 24 to 48 hours. If your INR is greater than 9, this is a minefield that you really have to be vigilant in stopping the Coumadin and treating with IV or pure vitamin K. Make sure that patient does not enter into bleeding scenario. Alright, just a quick medical minute then on anticoagulant treatment. Of course, the other agents that are sometimes utilized are the antithrombin inhibitors, and this is becoming more popular, especially when you realize that unfractionated heparin does have the potential for these side effects of heparin-induced thrombocytopenia and the decrease in the platelet count significantly, lending to bleeding further bleeding problems with heparin treatment. As we said, the warfarin, which is a vitamin K antagonist, is also used. One should not forget the factor 10 inhibitor, Arixtra, fans of Purinox. Alright, again, just a quick medical minute on anticoagulant treatment. Until next time.